Welcome to Roadmap to Residency's Board Exam Prep Series. Today we're diving into interstitial lung disease, one of the most commonly tested pulmonary topics on Step 2. Instead of lecturing you on every detail, we're going to focus on what really matters, recognizing the patterns that appear in question stems and using strategic test-taking approaches to get to the right answer quickly. Let's get started. By the end of this video, you'll be able to identify the classic presentation that distinguishes the major interstitial lung disease subtypes. You'll learn to apply elimination strategies when you're stuck between answer choices. And most importantly, you'll recognize the buzzwords that board examiners love to use for idiopathic pulmonary fibrosis, sarcoidosis, and hypersensitivity pneumonitis. For the complete pathophysiology, make sure you're reviewing first aid and doing practice questions in your question bank. Here's your framework for approaching any interstitial lung disease question. Step 1 is pattern recognition. When you see progressive exertional dyspnea over months, a dry, non-productive cough, and those classic Velcro-like crackles on exam, your differential should immediately narrow to interstitial lung disease. Step 2 is finding the cause. This is where test takers often struggle. Look for exposure history, which points to hypersensitivity pneumonitis. Look for systemic symptoms like skin lesions, eye problems, or lymphadenopathy, which suggests sarcoidosis. And when you have an older male smoker with no extrapulmonary findings, think idiopathic pulmonary fibrosis. Let's lock in these buzzword associations because they appear constantly on boards. For idiopathic pulmonary fibrosis, remember, older male, smoking history, honeycombing on high-resolution CT, and critically, no systemic symptoms. For sarcoidosis, the classic triad is bilateral hilar lymphadenopathy, erythema nodosum, and uveitis, often in a young African-American woman. For hypersensitivity pneumonitis, always look for an exposure, whether it's birds, moldy hay, or hot tubs, and symptoms that improve when the patient is away from that exposure. Here's your first practice question. Read it carefully and try to identify the diagnosis before I walk through the answer. We have a 68-year-old man with a significant smoking history, 18 months of progressive dyspnea, no systemic symptoms on history, Velcro crackles and clubbing on exam, restrictive pattern on pulmonary function tests, and honeycombing on imaging. What's the diagnosis? Let's break this down systematically. First, recognize the clues. The demographics scream idiopathic pulmonary fibrosis, older male with smoking history. The presentation is insidious and progressive, exactly what we expect. The physical exam shows the classic findings of Velcro crackles and clubbing, and that honeycombing on imaging is essentially pathognomonic. Now let's eliminate wrong answers. Sarcoidosis is wrong because there's no hilar adenopathy and no systemic symptoms whatsoever. Hypersensitivity pneumonitis is wrong because the question gives us no exposure history. Rheumatoid arthritis-related lung disease is wrong because there are no joint symptoms. Here's your test-taking pearl. Honeycombing on imaging plus absence of systemic features equals idiopathic pulmonary fibrosis until proven otherwise. The answer is C. Now let's look at a sarcoidosis case. This is a 32-year-old African-American woman with progressive dyspnea, dry cough, and painful red nodules on her shins. She has blurry vision and eye redness. The exam shows those nodules and fine crackles. Chest X-ray shows bilateral hilar lymphadenopathy. The question asks which test would best support the diagnosis. Take a moment to think through this one. First, identify the diagnosis. This is textbook sarcoidosis. We have the classic triad, bilateral hilar lymphadenopathy on imaging, erythema nodosum, which are those painful shin nodules, and uveitis causing the eye symptoms. The demographics fit perfectly with a young African-American female. Now evaluate each option. Anti-nuclear antibody is not specific for sarcoidosis. Angiotensin-converting enzyme level is often elevated, but it's not diagnostic and can be elevated in other conditions. High-resolution CT shows findings but isn't confirmatory. The test-taking pearl here is crucial. When the question asks for the best confirmatory test, tissue diagnosis is definitive. Non-caseating granulomas on biopsy confirm sarcoidosis. The answer is C, bronchoscopy with transbronchial biopsy. This next case tests hypersensitivity pneumonitis. We have a 45-year-old woman who raises parakeets. She has recurrent episodes of cough, dyspnea, and low-grade fever that occur 4 to 6 hours after cleaning bird cages. Her symptoms improve significantly when she visits her daughter for a week. Imaging shows ground glass opacities. What's the most appropriate initial management? Spot the pattern immediately. There's a clear temporal relationship between bird exposure and symptom onset. The 4 to 6 hour delay is classic for hypersensitivity pneumonitis. Most importantly, symptoms improve with avoidance, which is the key diagnostic clue. Now think about why other options fail. Steroids are reserved for severe or progressive disease, not first line. Antibiotics make no sense because there's no infection here. Bronchodilators won't help because this isn't asthma or chronic obstructive pulmonary disease. Here's your test-taking pearl. Antigen avoidance is always the first-line treatment for hypersensitivity pneumonitis. You have to remove the exposure before anything else. The answer is C. Advise permanent avoidance of bird exposure. Let's test your knowledge of idiopathic pulmonary fibrosis treatment. A 65-year-old man with biopsy-confirmed idiopathic pulmonary fibrosis and moderate disease asks about treatment options. Which medication slows disease progression? Think about this carefully because treatment of idiopathic pulmonary fibrosis is counterintuitive. Here's the key fact you must know. The only approved treatments for idiopathic pulmonary fibrosis are the antifibrotic agents pirfenidone and nintedanib. Neither reverses fibrosis, but both slow the decline in lung function. Now eliminate the distractors. Prednisone is actually harmful in idiopathic pulmonary fibrosis. This is counterintuitive because we use steroids for many lung diseases, but not this one. Azathioprine combined with prednisone was studied in trials and actually increased mortality. Cyclophosphamide shows no benefit. Your test-taking pearl. Immunosuppression is harmful in idiopathic pulmonary fibrosis. Only antifibrotics help. The answer is C. Pirfenidone. Here's a question testing sarcoidosis complications. A 28-year-old woman with known sarcoidosis presents with fatigue, polyuria, and constipation. Labs show elevated calcium and elevated creatinine. What's the mechanism of her hypercalcemia? Understand the mechanism. In granulomatous diseases like sarcoidosis, activated macrophages within granulomas express 1-alpha-hydroxylase. This enzyme converts inactive 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D. The result is increased intestinal calcium absorption, leading to hypercalcemia. Now rule out alternatives. Hyperparathyroidism would have elevated parathyroid hormone, but in sarcoidosis, the parathyroid hormone is suppressed by the high calcium. There's no cancer history to suggest metastases. No vitamin D supplementation is mentioned. Test-taking pearl. Whenever you see hypercalcemia in a patient with granulomatous disease, think ectopic 1-alpha-hydroxylase production. The answer is B. Let's wrap up with the key takeaways. When you see honeycombing plus an older smoker, think idiopathic pulmonary fibrosis. When you see bilateral hilar adenopathy plus systemic symptoms, think sarcoidosis. When you see exposure history plus symptom improvement away from the antigen, think hypersensitivity pneumonitis. For complete coverage of these topics, review the pulmonary chapters in First Aid and work through your question bank. And if you want personalized tutoring or guidance on your residency application, visit roadmaptoresidency.com to connect with our expert physicians. If this video helped you, please hit that like button, subscribe to the channel, and share with your study group. Thanks for watching. At Roadmap to Residency, our tutors are physicians who scored in the top percentiles on their board exams. They can help you develop the pattern recognition and test-taking strategies that make the difference on exam day. For deeper learning, use First Aid, your question bank, and the primary sources referenced in the pulmonary chapters. Don't forget to like this video, subscribe, and hit that notification bell so you never miss a new walkthrough. Good luck on your exam, and we'll see you in the next video.